So you're on your internal medicine rotation, and you come across a patient who's anxious, sweating, and has dropped 15 pounds even though they're eating all the time. Or maybe it's an elderly patient who's just, well, failing to thrive. You know what? Both of those could be the exact same diagnosis, hyperthyroidism. Being able to spot the classic and the not-so-classic patterns of thyrotoxicosis is a skill you've absolutely got to have down cold. Today, we're going to build that clinical picture, piece by piece.
All right, here's the plan. First, we'll get to the core of the problem, what I like to call the body's engine in overdrive. Then we'll see how that overdrive state messes with the heart, the gut, and the bones. After that, we're going to zero in on the most common cause, Graves' disease, and its very specific triad of signs. And to wrap up, we'll cover a really important diagnostic pitfall, the apathetic elder, a presentation you just can't afford to miss.
Okay, let's get right into the pathophysiology. At its very heart, hyperthyroidism is just a state of constant, relentless overdrive. I want you to imagine the body's engine is stuck with the accelerator pushed to the floor. That's what we call the hypermetabolic state. So how does this happen? Well, it's really a 1-2 punch. First, all that extra T3 and T4 cranks up the body's basal metabolic rate, so it's just burning through energy like crazy. Second, and this is just as important, it makes the entire body super sensitive to catecholamines. It's like it's amplifying your fight-or-flight response 24/7. This double whammy mechanism is what explains pretty much all the widespread multi-system symptoms we're about to talk about. So what does this hypermetabolic state actually look like in a patient? Well, first off, you get weight loss, even with a normal, or get this, an increased appetite. This is a classic super high-yield clue. The patient's eating more, but they're losing weight because their metabolic furnace is just burning so hot. And all that heat has to go somewhere, which leads directly to heat intolerance and tons of sweating. And even with all this energy being spent, patients often feel this deep fatigue and a specific kind of muscle weakness, particularly in the proximal muscles, making things like climbing stairs or even combing their hair really difficult. And that sympathetic sensitization we just talked about, you see it in action right here. Patients feel anxious, they're irritable, emotionally up and down. They often come in with this very fine tremor you can see when they hold their hands out. Of course, sleep is a mess, so insomnia is common. And on your physical exam, you'll find these really brisk, hyperreflexic, deep tendon reflexes. They are, quite literally and figuratively, on edge. Now, this systemic overdrive has some really serious consequences down the line. Let's focus on 3 high-yield systems that get hit particularly hard: the cardiovascular system, the GI tract, and the skeleton. Of all the things that can go wrong, the one that can become life-threatening the fastest is what this does to the heart. That constant sympathetic drive leads to sinus tachycardia and palpitations. But here's the big one. It can trigger atrial fibrillation. This happens in about 10 to 20% of these patients, and it's a huge risk for stroke, especially in your older patients. Over time, all this strain can even push the heart into a state of high-output heart failure. In the gut, everything speeds up, causing what we call hyperdefecation. And in the bones, thyroid hormone revs up osteoclasts, leading to more bone resorption, which means osteoporosis and a higher risk for fractures. Just a quick clinical pearl here. When your patient says they're having more bowel movements, you really need to clarify. Hyperdefecation means an increase in the frequency of normal-looking stool. It is not the same thing as true diarrhea, which would be loose, watery stools. That distinction is actually pretty key for your differential diagnosis. Okay, let's talk about the single most common cause of hyperthyroidism, Graves' disease. Now, it causes all the hypermetabolic stuff we've already discussed, but it also brings its own unique triad of features that are totally distinct and really pathonomic. The key to understanding Graves is its pathophysiology. It's an autoimmune problem, where the body makes these rogue antibodies called TSH receptor antibodies, or TRAB. These antibodies are nasty little mimics. They pretend to be TSH, latch onto the TSH receptor on the thyroid, and just keep the on switch flipped, leading to this totally uncontrolled production of thyroid hormone. But this autoimmune attack doesn't just stop at the thyroid. Oh no, it also targets tissues behind the eyes, which causes Graves' ophthalmopathy. You get inflammation, you get deposition of these things called glycosaminoglycans, and it literally pushes the eyeballs forward. We call that proptosis or exophthalmos. The same thing can happen in the skin, usually over the shins, causing this thick, non-pitting, kind of orange peel textured skin called pretibial myxedema or dermopathy. And then much more rarely, you can see clubbing of the fingers, which we call acropachy. Now, listen up, because this is probably the most critical takeaway about Graves. The eye problems and the skin problems are not caused by the high thyroid hormone levels. They're caused by the exact same autoimmune process that is also causing the high thyroid hormone levels. This is huge. It's why just treating the hyperthyroidism doesn't automatically fix the eye or skin disease. They are separate problems caused by the same underlying root cause.
All right, let's wrap up with one of the most important and frankly most frequently tested concepts in clinical endocrinology. This is the atypical presentation of hyperthyroidism in the elderly, something we often call apathetic thyrotoxicosis.
You know, we have this classic picture of a hyperthyroid patient, hyperactive, anxious, buzzing with energy. Well, in older adults, you need to be ready to throw that picture right out the window. The presentation can be the polar opposite. They can be lethargic, withdrawn, depressed, and weak. Those classic signs of sympathetic overdrive, like the tremor and the hyperactivity, often they're just not there. Instead, the main features might just be weight loss and fatigue.
And you can see why this is such a trap, right? Because of this masked presentation, the diagnosis gets missed all the time. An elderly patient with weight loss and lethargy, what does everyone immediately think? Malignancy. Or they get slapped with that vague label of failure to thrive. Forgetting to even consider hyperthyroidism in your differential here is a classic, and honestly, a dangerous clinical mistake.
Okay, let's boil this all down to the absolute essentials. Number 1, always think about the engine in overdrive. Look for the heat, the tremor, and the weight loss, even with a good appetite. 2, in any patient with thyrotoxicosis, but especially the elderly, you have to be vigilant about atrial fibrillation. 3, if you see the bulging eyes or that weird skin on the shins, you're looking at Graves' disease. And 4, maybe the most important, don't get fooled. In an elderly patient, apathy, withdrawal, and weight loss can absolutely be hyperthyroidism. So I'll just leave you with this question. The next time you're on the wards and you see that older patient who's losing weight and just isn't doing well, the patient that everyone else is already starting to work up for cancer, are you going to remember to add one simple TSH to those initial labs? Because remembering to do that, well, that could make all the difference.